What's up, my average med students? Thank you for watching this video and welcome to a new segment. We're going to start surgery now, and this is one of many parts to come. So go ahead and hit the subscribe button and press the bell icon to be notified for all future posts if you already haven't done so. If you like this content, please leave a like and share this with other average med students just like yourself. Let's get going. What's the mechanism of action for heparin? It binds to and activates antithrombin 3. What are some side effects of heparin? Bleeding complications, heparin-induced thrombocytopenia, also known as HIT. How do you reverse heparin side effects? Protamine sulfate IV, 1 mg of protamine sulfate per 100 units of heparin. Which lab test do you follow for heparin? Activated PTT, and this is for the intrinsic clotting system. What's the target value for therapy with heparin? 1.5 to 2.5 times the control. What are some risk factors for protamine anaphylaxis? Patient with DMT1 and status post prostate surgery. What's the half-life for heparin? About 90 minutes. How long before surgery should you discontinue heparin? About 4 to 6 hours. Does heparin dissolve clots? No, it only stops the progression of clots and allows the body to break them down. What is the drainage of the left gonadal vein and the right gonadal vein? The left renal vein for the left gonadal vein, and the right gonadal vein goes into the IVC. What is Gerota's fascia? It's the fascia surrounding the kidney. Prominent collateral circulations in portal hypertension. You have the esophageal, then you have the hemorrhoids, which are the inferior hemorrhoidal to the internal iliac. The umbilical vein stays patent, and this gives rise to caput medusae, and retroperitoneal via the lumbar tributaries. Which parts of the GI tract are retroperitoneal? Duodenum, ascending colon, descending colon, and the pancreas. What's the gubernaculum? Embryological structure that adheres the testes to scrotal sac, and use it to manipulate the testes during indirect hernia repair. Which artery bleeds in duodenal ulcers? Gastroduodenal artery. Name the lymph nodes between the pectoralis minor and major. Rodders. Left vagus nerve location on the esophagus. Anterior, and this rotates during development. Morrison's pouch. Hepatorenal recess, most posterior cavity in the peritoneum. Foregut is defined as the mouth to the ampulla of Vater, and the blood supply is the celiac trunk. What is the midgut defined as? The ampulla of Vater to the distal 1/3 of transverse colon, and the blood supply is superior mesenteric artery. What is the hindgut defined as? Distal 1/3 of the transverse colon to the anus. Blood vessels on a rib. VAN, so vessels, arteries, and nerves, and they run under the rib. What is the order of femoral vessels? On the right leg, left to right, you use the naval mnemonic, which is nerve, artery, vein, empty space, and lymphatics. What is the Hasselbalch's triangle? You have the inguinal ligament, epigastric vessels, lateral border of the rectus sheath. What's the nerve on top of the spermatic cord? Ilioinguinal nerve. What's Callow's triangle? It's a cystic duct, common hepatic duct, and cystic artery. What is Callow's node? It's a node found in Callow's triangle, cystic duct, and common hepatic duct, and cystic artery. What separates the right and left lobes of the liver? Cantel's line. This is the line from the IVC to just left of the gallbladder fossa. Gastronoma triangle. Junction of the second and third portions of the duodenum, cystic duct, pancreatic duct. 90% of gastrinomas occur in this gastronoma triangle. What artery is responsible for anterior spinal syndrome? Artery of Adamkiewicz. How to find appendix after found the cecum? You trace the tinea back, look for them to converge at the origin of the appendix. What is the space of Rhesus? Preperitoneal space anterior to the bladder. What are white lines of Tald? Lateral peritoneal reflections of ascending and descending colon. What is the strongest layer of the small bowel? Submucosa. Submucosa has superior strength. That's a great way to remember it. Which parts of the GI tract don't have serosa? Esophagus, middle, and distal rectum. Vein that overlies the pylorus. Vein of Mayo. Pouch of Douglas. What is it? It's the pouch between the rectum and the bladder and uterus. Where does thoracic duct empty into? Into the left subclavian vein at the left internal jugular vein junction. Coronary vein. Left gastric vein. Hypogastric artery is also known as internal iliac artery. Layers of the abdominal wall. You have the skin, Camper's fascia, which is fatty, Scarpa's fascia, less fatty, external oblique, internal oblique, transversalis abdominis, transversalis fascia, preperitoneal fat, and the peritoneum. What are plicae circularis? Circular folds of mucosa in the small bowel. Major structural differences between the jejunum and the ileum. Jejunum, longer vasa rectae, large plicae, circularis, thicker wall, and the ileum has shorter VR, smaller PC, and thinner wall. Ileum is inferior. Major anatomical differences between colon and small bowel. The colon has tinea coli and haustra, appendices, epiplaque, which are fat appendages. Small bowels do not have these. How high does the diaphragm extend? To the fourth intercostal space, and this is the nipple line in men. Dermatome of the umbilicus. T10. Major layers of an artery, exterior to interior. Adventitia, media, and intima. What is PT? Prothrombin time. This tests the extrinsic pathway. What is PTT? Partial thromboplastin time. This tests the intrinsic coagulation pathway. What is INR? International Normalized Ratio, and this is the method of reporting your PT. What clotting factors are missing from whole blood? Factors 5, factors 8, and factors 11. What does FFP replace? It replaces clotting factors and nothing else. What does cryoprecipitate replace? Fibrinogen, von Willebrand factor, and clotting factors. What electrolyte most likely is to fall status post-transfusion with stored blood? Calcium, because citrate is used as a preservative and this binds serum calcium. What changes occur when whole blood is stored? You have an increase in calcium, potassium, and hydrogen, and you have a decrease in 2,3-BPG and clotting factors, such as factor 5, factor 7, and factor 11, and your neutrophils. What indications are there for blood transfusion? Acute blood loss, hemoglobin less than 10 in chronic artery disease or CAD and COPD patients, and hemoglobin less than 7 in healthy patients. 1 unit of packed RBCs, what increases in hematocrit? Leads to what increase in hematocrit? 3 to 4% increase in hematocrit with 1 unit of packed RBCs. Who is the universal donor for packed RBCs? O negative. Who is the universal recipient for packed RBCs? AB positive. What is type and screen? You determine the blood type and you screen for antibodies to other types. What is type and cross? Patient's blood is sent to a bank and it's cross-matched for specific donors. Can you define thrombocytopenia? It's any time where platelets fall below 100,000. Common causes of thrombocytopenia in surgical patients. Sepsis, H2 blockers, heparin, DIC, and antibiotics. Drug to correct platelet dysfunction. 2 out of 2 uremia, aspirin, or bypass. You give them desmopressin. Common medication that causes irreversible malfunction of platelets. Aspirin, due to its COX inhibition. Platelet count is associated with spontaneous bleeding. Or which platelet count is associated with spontaneous bleeding? Anything less than 20,000. Minimum platelet count for surgery. Greater than 50,000. When should prophylactic platelet transfusion be given? When under 10,000. Differential until proven otherwise, or microcytic anemia in male or in postmenopausal female. Colon cancer. Why can't you infuse packed RBCs with lactated ringers? Calcium in the lactated ringer may cause coagulation in the line. How long can you keep packed RBCs? About 6 weeks. Symptoms of transfusion reaction. Fever, chills, nausea, hypotension, lumbar pain, chest pain, and abnormal bleeding. Transfusion hemolysis treatment. You stop the transfusion, give fluids, Lasix diuresis, which is furosemide, and this protects the kidney, and bicarb to alkalinize the urine. What's the most common blood product component to cause fever? WBCs. When to discontinue aspirin for surgery? At 1 week, platelets need 7 to 10 days to regenerate. Ways to move oxyhemoglobin dissociation curve to the right. It facilitates unloading of O2, so acidosis, 2,3-BPG, fever, and elevated PCO2. Think of a hard-working muscle. What factor is missing in Hemophilia A? Factor 8. Preoperative treatment for Hemophilia A. Factor 8 infusion to 100% normal levels. Coagulation study elevated in Hemophilia A. PTT. Factor deficient in Hemophilia B. Factor 9. How are hemophilias inherited? It's sex-linked recessive. What is von Willebrand's disease? Deficiency of von Willebrand factor and factor 8. Von Willebrand's inheritance pattern. Autosomal dominant. What drug corrects von Willebrand's disease? Desmopressin or cryoprecipitate. Von Willebrand's lab abnormalities. Elevated bleeding time. Cascade works okay, but it cannot stabilize the clots. What factors are deficient leading to hypercoagulable state? Protein C, protein S, and antithrombin 3. What causes a left shift on CBC? Lots of young neutrophils. So I guess I should have asked what is a left shift on CBC? It's lots of young neutrophils. What is the therapeutic INR? With Coumadin, you look for INR between 2 to 3. Most common inherited hypercoagulable state. Factor 5 laden. Classic position of a patient with peritonitis. Motionless, knees flexed. Classic position of patients with kidney stone pain. Restless and writhing movements. What lab tests are positive for acute abdomen? CBC with differential, Chem10, amylase lipase, type screen, urine analysis, and liver function tests. Lab test for every woman childbearing age with acute abdomen. Beta HCG. X-rays for acute abdomen. Upright chest X-ray, upright abdominal film, supine abdominal X-ray. Number 1 cause of right upper quadrant pain. Cholelithiasis. Most common cause of surgical right lower quadrant pain. Acute appendicitis. Most common cause of left lower quadrant pain. Diverticulitis. Endocrine causes of abdominal pain. Addisonian crisis. DKA. Which is worse, alkali or acid? In burns patients. Alkali. Body can't buffer. This leads to longer burn time. In burn patients, why are electrical burns more dangerous? Because the path of least resistance it burns tracks through the nerves, vessels, fascia, and usually it's worse than they look. Most common complications of electrical burns. Cardiac dysrhythmias, myoglobinuria, acidosis, and renal failure. How do you treat myoglobinuria? Hydration with IVF, intravenous fluids, alkalization of the urine with bicarb, mannitol diuresis, furosemide, etc. Furosemide won't help to pull non-transported solutes like myoglobin into the urine. You need osmotic diuresis. What is a first-degree burn? Painful, dry, and red, and it doesn't blister. And an example is a sunburn. What is a second-degree burn? Painful, hypersensitive, swollen, open blisters, and weeping surfaces. What is a third-degree burn? Painless, swollen, dry, mottled, white with charring, and it has a dried leather appearance. Major clinical difference between second and third-degree burns. Third-degree burns are painless. How do you measure burn severity? TBSA and depth of the burn. First-degree burn treatment. You clean the burn and plus or minus Neosporin, and you can give pain meds. Second-degree burn treatment. You remove blisters, antibiotic therapy. Dermis will often regrow from hair follicles and margins. Third-degree burn treatment. Early excision of the eschar, and skin grafting. Prophylaxis to give at the ED for burns patients. Tetanus shot. Lab value to assess smoke inhalation. Carboxyhemoglobin levels. Airway management in inhalation injury. Very low threshold for intubation. Swelling may occlude airway quickly. What is a burn shock? You have loss of fluid from extravascular 2 out of 2 burn injury. Fluid resuscitation strategy for burns. First 24 hours, you give crystalloid lactate ringer solution. 24 to 36 hours, you give D5W. Patients lose lots of free water by evaporation out of the wounds. And anything over 36 hours, you give colloid. And this is to stop capillaries from leaking. How to diagnose burn infections? Quantitative burn wound bacterial count. If it's greater than 10 to the 5th power per gram, then you give IV antibiotics. Why don't you give systemic antibiotics for burn patients? Bacteria lives in the eschar, so it's not perfused. Giving antibiotics will not work. Silver sulfadiazine. What are the pros and cons? Pros are it's an agent of choice for smaller burns. Cons: no Pseudomonas coverage, little eschar penetration, and may cause neutropenia. Mafenide acetate, also known as sulfamylon. What are some pros and cons? Pros: good eschar penetration, agent of choice for contaminated burn wounds. Cons: pain on application and misses staph, allergic reaction in 7% of the population, and acid-base disorders. Mafenide acetate causes metabolic acidosis. Polysporin in burns patients. Pros and cons. Pro: painless, clear, drug of choice for facial burns. And cons: narrow spectrum. Prophylactic systemic antibiotics. You don't give it for burns patient. What's a big complication for circumferential full thickness burns? Distal neurovascular impairment, similar to compartment syndrome. Treatment of distal neurovascular impairment. Escharotomy. Top 2 bugs causing post-burn pneumonia. First is Staph aureus, and second is Pseudomonas. Tetanus prophylaxis for burns. Yes, for everyone that's not immunized in the past 12 months, you give tetanus toxoid 3 times. How do you treat CO inhalation overdose? 100% oxygen. Electrolyte to watch most closely for burns patient. Sodium. What is rapid sequence intubation in anesthesia? First, you give first it's oxygenation, then muscle relaxant, cricoid pressure, intubation, and inhalation of the anesthetic. What are the induction agents for anesthesia? Propofol, midazolam, and sodium thiopental. What are some contraindications for succinylcholine? Burns, neuromuscular disease, paraplegics, and eye trauma, or anyone with increased intracranial pressure. Why does lidocaine burn on injection? It's acidic. It can add bicarb to help. What are some contraindications to nitric oxide? Any abnormal air pockets, middle ear occlusions, pneumothorax, small bowel obstruction, poorly soluble in serum, will expand into any open airspace. What's a feared side effect of bupivacaine? Cardiac dysrhythmia after intravascular injection. Bupivacaine toxicity steps. Excitatory inhibition of the inhibitory neurons, then it leads to depressant effects as activating neurons are inhibited. Medication that's contraindicated to Demerol. MAO inhibitors. Succinylcholine duration of action. Greater than 6 minutes. Early signs of lidocaine toxicity. Tinnitus, perioral numbness, metallic taste, blurred vision, muscle twitches, and drowsiness. Signs of large lidocaine overdose. Seizures, coma, respiratory arrest, loss of consciousness, and apnea. What is winged scapula caused by in breast cancer patients? It's a result of cutting the long thoracic nerve in a radical mastectomy. History risk factors for breast cancer. NAACP, nulliparity, age at menarche over 13 is bad, or less than 13, I believe. Age at menopause, anything over 55 is bad. Cancer of breast, self or family, pregnancy with the first child at an age older than 30 years old. What are 3 major types of invasive carcinoma? Invasive ductal over invasive lobular, and inflammatory carcinoma, in that order. What's peau d'orange? Inflammatory breast cancer. Best time to self-breast exam. 1 week after menstrual period. When do you start annual mammograms? At 50. What's the best option to evaluate breast mass in a woman under 30 years old? Ultrasound. Non-palpable mass on mammogram. How do you biopsy? Stereotactic versus needle localization. Breast mass workup. Clinical breast exam, mammogram, ultrasound, and then you do a biopsy. You find a cyst on breast exam. What's the initial test? Aspirate. If it's bloody, send it to cytology. If the mass persists, biopsy. Otherwise, you're done. When do you proceed to open biopsy of breast cyst? Second cyst recurrence, bloody fluid in cyst, and palpable mass after aspiration. How do you do staging workup for breast cancer? Bilateral mammogram, chest x-ray if you suspect lung metastases, a liver function test for liver metastases, serum calcium, alk-phos for bone metastases, other tests based on symptoms, bone scan for pain, and CT for neuro issues. Metastasis pattern of breast cancer. First, it goes to the lymph nodes, then the lung, liver, bones, and brain. 2 basic treatment modalities for breast cancer. Modified radical mastectomy, or you can do lumpectomy with radiation. Breast cancer treatment. When do you add radiation to modified radical mastectomy? And whenever you have greater than 4 lymph nodes positive, or if you have chest wall involvement. Tumor candidates for lumpectomy and radiation. Stage 1 and 2, greater than 2 centimeters in diameter with mobile axillary nodes, or greater than 5 centimeters with no nodes. Inflammatory breast cancer treatment. Chemo first. Contraindications to lumpectomy with radiation. Previous radiation to the chest, positive margins, collagen vascular disease, and extensive ductal carcinoma in situ. Tamoxifen side effects. Endometrial cancer, DVT, PE, hot flashes, mood swings. Adjuvant therapies, node positive for breast cancer. You get chemo. Adjuvant therapies for ER positive breast cancer. Get tamoxifen. Ductal carcinoma in situ, what do you see on mammogram? Microcalcifications. Ductal carcinoma in situ, what are some signs and symptoms? Usually none, and it's usually non-palpable. What do you see on histology for DCIS? Cancer cells in the duct, but they don't invade. DCIS is also known as intraductal carcinoma. What's the major risk for DCIS, breast cancer? It may develop ductal carcinoma in the same breast. What are some treatment options for DCIS? Lumpectomy with radiation, or total simple mastectomy, which leaves the nodes behind. When must you do a simple mastectomy in DCIS? When there's diffuse involvement or anything greater than 1 centimeter with contraindication to radiation. DCIS, does it need lymph nodes? No. DCIS adjuvant therapy. Tamoxifen or post-lumpectomy XRT. LCIS is defined as, and on histology, what do you see? Lobar carcinoma in situ. Carcinoma in lobules without invasion. LCIS signs and symptoms. None. LCIS mammogram findings. None. LCIS disease risk. It may arise from carcinoma, may lead to either carcinoma of either breasts. LCIS, most common type of cancer developed. Infiltrating ductal carcinoma in either breast. LCIS treatment. Close follow-up, bilateral simple mastectomy in high-risk patients. Number 1 cause of bloody nipple discharge in a young woman. Intraductal papilloma. Number 1 breast tumor in women under 30 years old. Fibroadenoma. Paget's disease of the breast is defined as scaling rash with dermatitis caused by invasion of skin by cells from ductal carcinoma. Number 1 type of male breast cancer. Ductal carcinoma almost 100% of the time. Male breast cancer presentation. Painless breast mass. Male breast cancer diagnosis. Mammogram and biopsy. Male breast cancer treatment. Mastectomy. If axillary nodes, then you clinically sentinel node dissection. If positive, clinically axillary node dissection. Most common cause of green or straw-colored nipple discharge. Fibrocystic fibrocystic disease. Most common cause of breast mass after trauma. Fat necrosis. What is Mondor's disease of the breast? Thrombophlebitis of superficial breast veins. How do you rule out spontaneous galactorrhea? Prolactinoma with prolactin level. Cystosarcoma phalloides is defined as, and what do you see on histology? Mesenchymal tumor from lobular tissue. Cystosarcoma phalloides, usual age of the patient. Greater than 30 years old. Cystosarcoma phalloides, signs and symptoms. Mobile, smooth mass, looks like a fibroadenoma. Cystosarcoma phalloides, diagnosis. Core biopsy excision. Cystosarcoma phalloides, treatment. If benign, wide local excision. If it's malignant, then you do a simple total mastectomy. Fibroadenoma is defined as, and what do you see on histology? Benign breast tumor, overgrowth of stroma, leading to causing collagen swirls. Fibroadenoma clinical presentation. Solid, mobile, well-circumscribed mass. Fibroadenoma diagnosis. Negative needle aspiration, ultrasound, core biopsy. Fibroadenoma treatment. Surgical resection if large or growing may be observed if it's small. Fibrocystic disease, what do you see on histology and how is it defined? Common benign lesion with cystic rubbery changes in the breast. Fibrocystic disease, signs and symptoms. Pain, tenderness varies with menstrual cycle. Fibrocystic disease, what's the diagnosis? Or how do you diagnose it? You do H&P, aspirated cysts, straw-colored or green fluid. Fibrocystic disease treatment. You stop caffeine, pain meds, and vitamin E. Appendix blood supply, what is it? Appendiceal artery. Mesentery in the appendix. Mesoappendix, appendiceal artery lives in here. Appendicitis causis. Lymphoid hyperplasia, fecalith, number 1, more than parasites, foreign body, tumors, etc. Appendicitis CT findings. Periappendiceal fat stranding, appendiceal diameter greater than 6 millimeters, and periappendiceal fluid. Appendicitis treatment of non-perforation. Prompt appendectomy, 24 hours of antibiotics. Discontinue POD number 1 first. Appendicitis treatment of perforation. You do appendectomy, drain pus, and CX. Post-op antibiotics, 3 to 7 days. Wound often left open. Appendicitis treatment of appendiceal abscess. PCT drainage, antibiotics, elective appendectomy about 6 weeks later. Appendicitis, bacterial infection that mimics what? Or what is a bacterial infection that mimics appendicitis? Yersinia enterocolitica. Most common appendiceal tumor. Carcinoid. Treatment of appendiceal carcinoid tumor. If it's greater than 2 centimeters, you do a right hemicolectomy. If it's less than 2 centimeters, you just do an appendectomy. Appendicitis during an appendectomy, what do you see? Or you're seeing creeping fat and obstruction. What is this? A Crohn's disease. You do a stricturoplasty. Appendicitis during an appendectomy, you see lymphadenitis. Then what is it? You don't do anything. It'll self-resolve. During appendicitis, or during appendectomy for appendicitis, you see tubo-ovarian abscess. What do? Culture and give IV antibiotics. During appendectomy for appendicitis, you see torsed ovary. Oophorectomy. During appendectomy for appendicitis, you see PID. What do? Antibiotics. During appendectomy, you see Meckel's diverticulum. What do? You resect it. During appendectomy, you see massive inflammation with abscess. What do? You drain, give antibiotics, reopen in 6 weeks for appendectomy. Medical treatment for carcinoid syndrome. Octreotide. What is the cell of origin for carcinoid tumors? Neuroendocrine cells and Kluchitsky cells, more specifically. What do they secrete? They secrete serotonin. What are some symptoms of carcinoid tumors? They are often asymptomatic, non-specific abdominal pain, pellagra, skin changes, diarrhea, dementia, and dermatitis. Medical treatment of diarrhea in carcinoid syndrome. Ondansetron, which is Zofran, which is a serotonin antagonist. Most likely site for carcinoid to metastasize from. Ileal primary tumor. Signs and symptoms of obstructive jaundice. Dark urine, clay-colored stools, pruritus. Black pigmented gallstones. What causes these? It contains calcium bilirubinate and it's from hemolysis or cirrhosis. Brown pigmented stones. What does it contain and what causes it? It's associated with biliary tract infection. What are yellow stones? For gallbladder. Cholesterol. Indications for cholecystectomy in asymptomatic patient. Sickle cell disease, calcified gallbladder, and kids. What is sclerosing cholangitis defined as? Multiple inflammatory fibrous thickenings, bile duct walls, leading to biliary strictures. Sclerosing cholangitis natural history. Progressive obstruction leading to cirrhosis and liver failure. 10% of the time it can develop into cancer. Sclerosing cholangitis major risk factor. IBD, more so in ulcerative colitis than Crohn's disease. Sclerosing cholangitis signs and symptoms. Same as obstructive jaundice, dark urine, clay stools, and pruritus. Sclerosing cholangitis diagnosis. Elevated alk phos, PTC, ERCP shows beads on a string appearance. Sclerosing cholangitis management. You do dilation with balloon, transplant, hepatoenteric anastomosis. Gallstone ileus is defined as small bowel obstruction happening when gallstone erodes through the duodenum and into the bowel. Gallstone ileus, classic site of obstruction. Ileocecal valve. Gallstone ileus, diagnostic imaging. What do you see? Or what do you do? AXR with obstruction and air in biliary tree. UGI may show cholecystenteric fistula. And abdominal CT, you see air in the biliary tract and may see gallstone blockage. Gallstone ileus management. Surgical. Enterotomy with stone removal and fistula closure. Gallstone cancer, most common histology type. Or gallbladder cancer, sorry. Adenocarcinoma. Gallbladder cancer risk factors. Gallstones, cholecystenteric fistula, porcelain gallbladder about 50% of the time. Gallbladder cancer tests of choice. Ultrasound, abdominal CT, and ERCP. Gallbladder cancer route of spread. Contiguous to the liver. Gallbladder cancer management. Confined to the mucosa, cholecystectomy, confined to muscularis serosa, radical cholecystectomy, and you take some of the liver and some of the lymph nodes. Cholangiocarcinoma is defined as malignancy of extra intrahepatic ducts. Gallbladder cancer histology. Adenocarcinomas. Gallbladder cancer signs and symptoms. Signs of biliary obstruction, jaundice, clay stools, and dark urine. Cholangiocarcinoma risk factors. Colodocal cysts, UC, sclerosing cholangitis, liver flukes, clonorchiasis. Cholangiocarcinoma treatment. Proximal duct resection plus Roux-en-Y distal duct and Whipple procedure. Porcelain gallbladder. It's BG calcified with scar tissue. Must remove 2 out of 2 high incidence cancer. It has a high incidence for cancer. Hydrops of gallbladder. What is this? Complete obstruction of cystic duct by gallstone. Gallbladder fills with fluid, not bile, from mucosa. What is Gilbert syndrome? Problem with bilirubin uptake and causes occasional hyperbilirubinemia, but it's not dangerous, pretty benign condition. Alright guys, that about wraps it up. Thank you for watching, and if you liked this video, please share. Today we completed about 249 cards. It's not bad. And stay tuned for part 2 of the surgery video. There's going to be lots of videos coming. You don't want to miss out, and I really hope this is helping you. If you have any comments or suggestions or even any corrections to any wrong information that I may have presented, please go ahead and leave a comment down in the comment section below. And have a great day, guys. Bye-bye. Try to isolate, side to cyberspace. Now I